mitigate and kind of keep the candidiasis at bay. It's not, a sure cause of not having it, but it's a way that we can actually limit it, the infection. All right, so why in children is it more prone, or in infants?
I thought that,
and then you immediately thought, why?
Is it because breastfeeding, like the bacteria?
Well, there's the bacteria. What else? I mean, what about an infant's immune system?
it's not as strong.
It's not strong. And then also, what can happen if they're having a vaginal birth?
You're transferring that.
You can transfer it in there. So that's the main reason why they can have that in their mouth as well. And that's why you want to make sure when you are pregnant that you're going to your OB, just to make sure that any type of infection is cleared up prior to giving birth. All right, so we already know about, tell me about dentures. Why? And what does it look like? Tell me, and this, we're going into this longer, but what is it caused? Or what is it, what am I trying to say?
How does it cause it?
No, like what is the, yes, there we go. I'm like, the thing. Gotcha things on the palate of the mouth. Right. And what causes that? Not removing it, not letting air in. And so what are some ways that we can prevent that when we see that in our patient?
Tell them.
Remove it.
To remove it, to make sure it's clean, they can actually soak it in an antifungal rinse or in a bleach solution, as long as there's not a metal base. So we don't want them taking just regular bleach and throwing in their denture in there and saying that you told them to do it. It has to pretty much be all acrylic. So, and it has to be a 50-50, solution. All right, and then we know about xerostoma, stomia that could actually cause it, and then we already talked about pregnancy. All right, so this is going to be important for when you're going into boards and when you're going into pharmacology, and then also for your exam. So we have a systemic and a topical. So for our topical, our nystatin and our clotrimazole, those are what we always want to go to for antifungal agents, just because systemically it can cause any other type of reaction. So we always want to go the topical route. If there is needing to be any type of systemic reasoning for it, then we go to fluconazole and ketoconazole. I want you guys to definitely remember these medications. These are going to be reappearing from here on out. So we already talked about topical is the preferred method, just because you can have severe reactions when we're going into systemic. So any way that we're talking about systemic medications, we always want to go the topical route, which kind of is funny because when I was at my son's camp, which was like hell on earth those 3 days, they made us, I didn't do it, my girls' cabin did it. They made the girls put on these rain boots and made them go into the lake. Now at this time it's 9:30 in the morning, super cold, and there was water in the rain boots because everyone had been wearing these rain boots. So one of the little girls, her name is Sydney, she's like, I'm going to get a foot fungus. I said, yeah, you may. I'm not trying to freak you out, but if I were you, I sit this one out. But so the camp counselor was like, take your shoes and your socks off because your socks are going to get wet if you put your feet in here. So they're putting their feet into these nasty rain boots. And so Sydney is just freaking out. She's like, I can feel it. I can feel the fungus kind of coming in. What am I supposed to do? I was like, can you go get some nystatin? He's just looking at me like, what? But I was freaking out for her because I was like, I don't know what to tell you.
Spray some Lysol on that?
Why? And I should.
Like
and I brought my Lysol IC to spray down my whole cabin when I came there. But because that's just the kind of person I am. But I should have brought it out there. But they made them go in there and had these little strainers and strain for invertebrates, which was ridiculous. And so then they're falling in the water. It's like 40 degrees outside. It was just a hot mess. But anyway, it made me think about that because I told her, I was like, you need to get some nystatin and rub that in. She ended up getting my antibacterial solution and rubbing on her feet. It was It was weird.
She was like a mini you, huh?
Yeah, she really was. I was like, oh. She also has a crush on my son, so I was like, oh, this is perfect.
You can give nystatin like as a liquid by mouth too, can't you?
Yes, you
Okay.
can. Yeah, and so and then even in a dental clinic or in your dental office, you can give it to them. Right.
So that would be the
That would be
systemic
systemic.
version?
Yes.
Okay.
All right, so we're gonna go through these different types of candidiasis. We're gonna go through it one by one in each slide. So pseudomembranous candidiasis, what's another word for this? There we go, thrush, very good. All right, so we already know it's like that white curd kind of feeling over there. We can wipe that off. Once we wipe it off, we have that red erythematous coating underneath it, which can be painful, can be not, but it can also be very sensitive depending what's going on. And we can always do a microscopic or histologic smear to make sure that it is candidiasis. So it's more common in infants, older patients, diabetic patients, or debilitated patients, anyone with a weakened immune system pretty much, which all of those fall into those categories. So always just think of candidiasis, immunosuppressed. If you think about that, you're gonna already think about these categories that it's gonna fall into. Oh, picture, sorry. I'm just going through it. This is kind of what it looked like when I saw my patient, which we'll get in when we start talking about AIDS and HIV, but he had it all over and all the way down through his throat. All right, so erythematous, God, I can't say that word. So what this is pretty much is that red inflamed area. So with this, it's more looking like that we get it from a broad spectrum antibiotic, which is what is considered a broad spectrum antibiotic.
Is
We
that
think
like
about it.
Z-Pack? Like
Z-Pack, any type of amoxicillin, penicillin, anything that's going to kill a gram positive, gram negative, or any type of wide range of bacteria, as opposed to a narrow spectrum, which is just specific to that bacteria or that virus. All right, so we already know that once, the whole thing about this is that when we're looking at any type of candidiasis, a lot of it's gonna be our therapeutic diagnosis. It's gonna be a clinical / therapeutic, because what you're gonna do is look at it clinically, you're gonna wipe it to see if it wipes away, that's gonna rule out leukoplakia. And then you're gonna go ahead and prescribe, well, you're not gonna prescribe, but you're gonna recommend any type of antifungal agent. Once the antifungal agent is then given to the patient and the patient takes it, if it's gone away, then we have our therapeutic diagnosis, because we're already thinking, okay, this is what it is clinically. We're gonna give you a medication. We're gonna see if that medication works. If it works, there we have it. Same thing as like scurvy when you start increasing their vitamin C. Once it goes away, that's our therapeutic diagnosis of knowing, okay, once we administer something and the illness is then dissipated, then we already know what it is without any further. You can always go and do a microscopic diagnosis just to clear it out, but there's really no need for that when we're looking at things like thrush or angular colitis. Okay, so this is more seen like in HIV or AIDS patients, but what else does this look like?
geographic.
Medium rhomboids. Exactly. So could I give you this picture?
No.
Mm.
Without information.
Right, yeah, exactly. So I would have to give you some type of backlog or some type of, in a case study or so, because giving you this picture alone, you would not know if this is medium rhomboid glossitis or erythematous candidiasis. But looking at that before and then after antifungal treatment, doesn't it look beautiful? All right, so chronic atrophic candidiasis. So this is what we're seeing mostly in our elderly patients. This is also what we're seeing when we're looking at denture stomatitis, when they're not removing their dentures. So I know you guys hate knowing two different words, but you gotta know it. So just make sure when you're putting them together, you're putting this together with denture stomatitis, and then you're gonna kill two birds with one stone, because you already know what causes it and what it looks like. All right, so we already know it affects the elderly, what to do to remedy it, so we really don't have to spend time on that. We already know what the treatment is, and I already discussed soaking in bleach solution, removing denture, and then antifungal agents. And you've already seen this picture. All right, so this is our candidal leukoplakia. So once again, we discussed before is that this does not rub off, but it's not leukoplakia in the sense that we're not going to look at it as a precancerous leukoplakia. With this, we would have to do a histological smear to make sure that it is candiditis and that it is not something that's related to cancer or precancerous. So what we would just have to do is just make sure we do this the smear, and then knowing which kind of areas is that it's actually more prevalent on. But even knowing those areas that is more prevalent, it's the same areas as leukoplakia is more prevalent. So the only thing you could honestly do is just do a histological exam. And then treat it therapeutically as well to see if it goes away. So we would also do the clinical diagnosis, a therapeutic, and then a microscopic diagnosis. And these are things I want you guys to kind of look at too. So if I were to give you case studies or give you questions to know, okay, well, what type of diagnosis would you do? Like, where would it stop? Where could we stop at if we just saw something clinical, or how would we have to keep going? So like for candidal leukoplakia, you would need to go to the microscopic one, even though we would still do the therapeutic diagnosis. The only reason we wouldn't need to go further is because when we wipe it, it's not wiping off. So it's not giving us that clear, definitive, clinical aspect of this is candiditis, because it's not wiping off. So you would still want to do a microscopic or histological examination.
Are there gonna be test questions like that, like how far diagnosis?
Will I do that? No.
Okay.
Will your boards do it? Yeah, in your case studies. So and that's what I was talking to the seniors yesterday. It's just, when it came to their case studies, and they gave me horror stories about it, so I'm a little worried about your boards. But, there's just a lot of information that they have to kind of go back to, like way back, like in pre-recs back. So, we're just trying to get you to know how to think of using all the information, because we really don't know what they're gonna ask you, but it seems like they're asking you guys some really off-the-wall questions in your case studies. Not to freak you out or anything.
Did they say anything about not having the,
It's on there. All of them said. So Rachel had one, the rest of them said they had about like 2 or 3. So it's still not a
really,
lot.
if there's like one, why? I don't know.
Right. But there are a lot of accept questions,
Yeah.
which Liz said threw her off a lot, because she had like 5 in a row that were accept, and then had one that wasn't an accept, but you're already in the mind frame of doing accept, and so
That's wrong.
yeah, it is wrong. That's kind of evil. But so they did want more of those and thought that would be better for you guys to get tested more in the accept, which we do. So I think we're just going to still keep it as, maybe 1 or 2 questions for the cause and effect, and that's pretty much all you really need. Okay, so chronic mucocutaneous. This I want you to kind of keep in mind that this is going to be with a systemic antifungal. So everything else can be treated with any type of topical, but this one is going to be with the systemic one. So knowing where the areas that it can affect, but the main thing is just knowing where it's treated. So make sure that you have that in there. All right, angular cheilitis. What is this? Where is it located?
Right in the corner there.
What causes it? What can cause? What are some of the causes of it?
Xerostomia,
Xerostomia,
edentulous.
edentulous, and why? It's because
Your muscles all.
it's all kind of sinking in, and so what's going on is that there's a lot of just the saliva around there, that moist area. It's the same thing as how you can get it when people like to lick their lips a lot. Don't really understand why, but so any type of moist environments where they're going to be getting that a lot. Mainly, it's going to be in our elderly patients. We can see it in our HIV or AIDS patients as well, which can be a telltale sign of that, knowing that they're immunocompromised at that point. And then looking at nutritional deficiencies, which we'll get in more into when we start talking about nutrition, but knowing that there's a deficient in vitamin A, definitely vitamin C, those can cause that angular cheilitis as well. So looking at your patient in a whole to see what could be possibly going on, if there's a nutritional deficiency, if we can go ahead and increase that. Usually with that patient, it can be, they may be elderly, they may be younger and they're just having a deficiency, or they're in the sun a lot. So we have to kind of figure out what's going on with the patient before we start trying to get a differential diagnosis. you guys already knew that. All right, we already know about median rhomboid baculositis. We're not gonna spend a lot of time on that. Okay, so deep fungal infections. This is something very rare. Your book kind of touches on it a little bit. The only thing I really need you to know are these fungals. So I need you to know the organisms. So histoplasmosis, blastomycosis, and cryptococcosis. Knowing those. Hint, hint. Also gonna be on your, what are we doing? Kahoot.
So that's all we need to know is that they're
Pretty much from this. Yeah, I mean, there's not a lot you really need to know from this because it's very rare. I mean, it's more prevalent in Western societies, but it's very rare in our area.
But those
We don't need to know
all
that,
we need
though.
to know is that they're fungi.
Yes, yes. Are we good? Okay, going into viral infections. Verruca vulgaris. All right, so we already know this is the common wart. Tell me about it.
It's raised with a sessile base.
Is it always a suspect?
No, it can be pedunculated.
Pedunculated too. So we know it's caused by the papillomavirus. This is pretty much the most common area, and we know it's going to be on the skin or oral lesions. A lot of times this is what can lead to, and we'll get into this, to our herpetic whitlow as well, which is what? I know you guys know this already, Ms. Campbell. Where is it located? Where is herpetic whitlow? You guys don't know? You guys haven't heard of it?
No, I've heard of it, but I've heard of it.
Yeah, it's gonna be on your finger. Well, that's herpes, so I'm all over the place. But, and I don't know why I'm talking about that with warts, but anyway. So with this, when you're seeing these, you wanna make sure that it is self-inoculating. So, you know, you don't wanna have your patient or you biting your fingernails or when you have an active wart there, that you don't want them to kind of touch areas because it is very contagious and it can spread. How can you remove it? What's the,
Freeze it.
freeze it or?
Use the is it like an
It's an acid, right? So it's salicylic acid,
or they cut it out.
or they can be conservative with surgically removing it as well. With this, I want you to know that with the Verruca vulgaris, that they're white. Because when we go to the next one, it's going to be a different color, so that's where you're going to be able to differentiate which one is which. Okay, so we're looking at the clinical appearance, biopsy, and then presence of lesions anywhere else. So we already went over treatment. So there's medication. So Aldara is a medication topical-wise that can actually minimize the wart as well. I haven't really heard a lot of success about this. So I mean, the main ones I've always heard about is either freezing them or surgical excision.
No, I know some people can put like duct tape. I've seen people do it. I think
Done
I've
that with plantar wart.
Yeah, it'll
Right off.
And
it
it like suffocates.
suffocate. Like, how does that
Really?
work?
I have no idea.
But
I'm
yeah.
gonna
It
have to look
doesn't
that
let
one.
any oxygen get to it.
It does
works.
work though. Like, it's insane.
Kind of like a band-aid.
How
but
long
you-
does it go?
I
I mean,
need
what's
that.
the duration?
This is gonna be really gross.
Just as long as
I had a
it
plantar
takes
wart
for
on
it
my
to go away.
toe, and I just duct taped
Mhm.
it for like a week,
It
and I
just-
just pulled it off,
yep.
and the wart came off with.
I feel like it kills it. Like it just.
It just
doesn't-
has
Suffocates
no.
it.
It just pulls right out.
Huh.
It's
works.
a lot better than like freezing. I didn't think it hurt, but I left it on for a long time.
And you just leave
But
it
like
on.
my sister had one, she froze it, and she was in a lot of pain, so I tried the duct
So
tape.
you just bathe with it?
Mhm. The duct tape just seals
Don't
it
you
up.
have to keep replacing
You just
it?
clean it,
Yeah,
but you keep it
replace
covered.
it, but you have to like.
Keep it covered as much as you can.
Yeah.
Huh. For like a week?
Or
Yeah,
as
a
long
week
as
or
it
it depends on the
stays.
size.
You could take.
So you just keep
longer.
looking at it
Yep.
and seeing.
nail polish too, but
You put nail polish
This is
remover.
super weird.
no, not remover.
No,
When I was
clear.
younger, I had one on my foot, and like, I don't know where my mom heard this, but you like cut a little square of a banana peel, and then you just tape it on there like every night, overnight, and that makes it go away too.
Did it?
Yeah, it worked.
Oh wow.
I don't know how.
I wonder if it's like the stuff that's in the peel, like the.
Well, I could see that with the potassium and the other nutrients
But
in
duct
there, but I
tape?
don't understand duct tape.
got chemicals
because-
in it?
Yeah, exactly.
Yeah,
Duct tape is man-made, so, but I mean, there's also chemicals in bananas.
This is gonna sound crazy, but I used to have a wart on my thumb when I was little, and my uncle found like this plant in his yard, and he wouldn't let me see what it was, and he like put it on there, and it was gone in like a month.
This your uncle growing. Did he find it or did he grow it and then
It
took
made
it?
me close my eyes.
He didn't want to tell the teacher.
It was probably St. John's wort, and he just lied to you and was like,
Oh, really?
I'm just kidding.
Do we need to know the medication for this one, or just know that it's frozen?
Yeah, I just want you to kind of know the, pretty much the treatment of it. You're not gonna have any questions about this medication at all, but just know that it can be treated with medications. I wouldn't put in there about banana peels or duct tape, or, plants growing in Jessica's uncle's garden.
Homeopathic?
But just stick with surgical and medications. All right, so then we know it can reoccur, and we already talked about any type of topical acids that can actually remove it and burn it. All right, so condyloma acuminatum. So this is the one that I was saying that you want to know the difference between the two, because verruca vulgaris is going to be white, this one is going to be pink. So these are going to be your telltale signs of knowing. They're all caused by the papillomavirus, transmitted oral cavity, also self-inoculating, and this one has that pedunculated base and has the pink color as well. So that's what I definitely want you to take away from that, is that with our condyloma acuminatum, it's going to be pink. Our verruca vulgaris is going to be white. All right, so we know this is a sexual transmitted disease. I know,
Sorry.
but I had to kind of group this all together into just being, I don't want you to, see, promiscuous. So not all homosexuals are going to have it. Just anyone who is very overly
Active.
sexually active. Just think about that. All right, and then also anything that you'll go into when we're in this time next year and we talk about our darkness to light and we're going into child abuse is also knowing telltale signs of child abuse as well. So if we're seeing this in a child, we have to think about sexual abuse to a child. This kind of goes over the same thing we just talked about. The only thing that we didn't with this one is the same thing as our verruca vulgaris, which is going to be the conservative surgical treatment, and that this one is reoccurrence is more common.
They both can reoccur though, right?
Yes.
Ooh,
This one just.
that one is like a,
I feel like I'll be good with anything but this.
ooh.
Like,
Can you
it's
What
not
does that
milky
mean?
and salty. It just means that just gross.
What is that growing on? They're
I
like,
think she means like the blood and the pus and
Yeah.
everything.
Oh, I thought you meant like good with any other STD, but this, I was like, you need to explain
No,
this.
like I'm fine seeing anything
Oh,
but this.
yeah, that right there would kind of.
yeah.
I think it's
That's
more
like a
like
little
the
plant.
twinkly thing.
Oh,
Ew.
that's under the
I
tongue.
mean, I don't.
I wonder,
How do you keep your composure when you see it?
You keep your, what are you supposed
Because
to
if
do?
I see
Start
that, I'm gonna
screaming?
be like, what the
Judgmental?
heck is that in your mouth?
No filter.
I'm just getting
Yeah.
like freaked
You
out.
can't do that.
And you won't mean to be, you'll
You
just be
just
like,
have
whoa.
to say, have you noticed anything under your tongue recently?
What you
Let
been
me show
doing?
you.
What you doing?
Look at this.
Like that.
Oh. But I mean, they apparently don't have very good oral health anyway.
Yeah, there's a lot going
Oh,
on.
wow.
Look at their teeth.
You got some
Well,
material
it
alba.
depends on how thick they are and how pedunculated it is. So some dudes, you can't palpate it though, so you touch it.
Ew,
but
no.
It's not gonna be.
I'll just take its word. and just try to do
She said, I'll take its word.
You guys are horrible. Now I want you to look at this as
Those are
well,
horrible.
and I want you to look.
missing tooth.
Well, not
It's a
that.
child.
It's a child.
Oh.
We have the mammal on. So looking at this, I want you,
Mm.
you would have to, and it is our due diligence when we do notice things like this within a child to actually
Report.
tell your dentist and then report.
Is there any way for them to get them without it being sexually transmitted?
I mean, they can. I mean, depending if it could be a caregiver that could have it. I mean,
It could even be the mom, and she's sharing drinks and food.
and that's it
all
too.
that.
So we can't really jump at it and say, I mean, that's with anything. So even like, with any type of herpetic lesions too. But I mean, knowing how, I guess is, if we saw more of these lesions, everywhere, then we would kind of have to, ask questions. But you would still ask questions without going first thing into child abuse or
Well, you
sexual abuse.
Could ask them, like, ask the parent how long has this been there, and if the mom goes, well, I have those too. I just thought it was, and
Right,
then
and
you'd be
that's
like,
something.
oh.
Or if they say, I didn't know that happened, and the child starts opening up, then, which can happen too. All right, so multifocal epithelial hyperplasia. So this is also known as Hex disease, which I need for you to make sure that you understand that this and those are pretty much the same thing. Common in children and teenagers. So this is, unlike mononucleosis, it's kind of the same thing as the kissing. So it's close contact with one another. So you're going to actually have more of these warts kind of showing up. They can last anywhere for a couple of weeks. They go away spontaneously. It's not really appealing, but that's why it's multifocal.
Ooh.
That hurt.
Yeah, I would think so. I don't
Are
know
they
firsthand, and I've never seen it
Fluid
firsthand.
filled?
What?
So it looks like there's three.
Yeah, and I didn't even notice that until you said that, but it really does. I guess that one is labial right, I guess. But.
Maybe those are his laterals and he has one central.
Just one.
Oh my
Guys, do Alright, so going into herpes. It's just like, ugh, for me, I can't. But, so we have herpes simplex 1 and herpes simplex 2. Tell me about the difference between the two.
One is oral, one's more vaginal or genital.
Okay, so which one is oral?
Simplex 1.
And then genitalia is gonna be 2. So that we know that pretty much the majority of a population is gonna have this. There's 85% or either a third or a half of the population is going to have it, the virus within them. It can be latent as well, which means what, Emily?
It's dormant.
Right. So, which means that once you've been inoculated with the virus, it may appear, you may have the first primary symptoms of it, and then it could remain latent. A lot of us could have it and it's never had an outbreak either. This is all at HSV1. So just knowing that, you can have a patient that may have the virus but may be asymptomatic. So, you have to be careful with your patients, or just them not knowing. Like for me, I've never had a cold sore or fever blister before, but that's not to say I don't have the virus that's latent. My mom has it, so, and hers, when she's stressed comes up. So I'm pretty sure with it being my mom that I have the virus, it's just latent. Now, if I were to get sick or something like that, which happened with, I was reading an article with a lady who was hospitalized and never thought that she had the herpes simplex virus, and her immune system was so weakened that when her daughter came back in, I think the next day, her whole body was broken out in lesions. And it's just because it was, it was pretty much opportunistic, where her immune system was so suppressed that it was no longer to fight or keep the virus dormant, and it just reacted everywhere. So you look at that and you're like, okay, well, I never knew that my child or my loved one ever had a fever blister or a cold sore or ever had an outbreak, and then you come in there and you see that, just knowing that the virus is more likely to be latent in that, it came out during a immune suppressed event.
So once you have a virus, you always have it. It doesn't ever go away. Yeah, it's a trick thing, isn't it?
Right, because if there's no vaccination, then yes, kind of like with the chickenpox. If you have the chickenpox, or it's always going to stay latent or dormant in your body, which is why you can get shingles. So, but for some, did you get the vaccination?
No, I had to.
Okay. So for like some of us who had to get, who had the vaccination, we weren't vaccinated for it, we're more prone to shingles. As the ones of you who all got the vaccination, yeah, at a certain cutoff.
I had chickenpox, and I wasn't immune, and I had to get the vaccinations.
You had it? You got the vaccination?
I had it when I was a kid, and we had to get a titer, and it came back negative or whatever it was. Like I wasn't immune, and I had to get the.
Can I get that again? Like chickenpox?
Can you get it again? So no, you're not gonna get it again. So chickenpox is not gonna come back, but
No.
shingles. Oh,
The-
chickenpox
the
vaccination?
vaccinate,
I-
yeah, the-
I mean, I guess.
just in case, you know, like if it doesn't work. I wanna make sure, like, I'm good.
But so most viruses without a vaccination on there, so yeah, if you have a virus there and it's not been cured, it's gonna remain latent, and so you will.
But can it be cured? That's what I'm
Hey,
wondering.
you can get a
Certain
titer.
viruses can, so
You
like
can get a
right
titer
now,
to see
we
if
have,
you're
right now, there's
immune
two
or not.
cases
We had to
out
have a
there
titer.
that
I had
have,
to.
the
Even though we
AIDS
didn't have the
patients have been
vaccine,
cured,
we
not
had- I had
HIV, but AIDS
Because I had
cases, so now they're
chickenpox,
trying to
I
say
had
there's a
a
cure
titer
for
for this
AIDS.
Wow.
Not the HIV,
Right,
because they're
so-
able to keep drugs right
Titer.
now to keep the HIV from
say
progressing
whether
into
I was-
AIDS, but they're saying there are
What do you
two
know?
cases right now where they've had, yeah, so if
You
that's
probably
the
have
case and
vaccine.
you have the virus and then there's a cure
See, I didn't
for it,
have-
it's going to
I
kill
took
the,
vaccine.
the disease
They didn't do
itself,
that.
the virus. Just like with, what am I thinking of, the liver,
Hepatitis?
not hepatitis. I'm like, I knew it started with an H. I want to say herpes so bad, and I'm like, it's liver. Hepatitis. So right now we have a vaccination or a cure actually for hepatitis. So everyone who had hepatitis C, and it's still super expensive, but you have this disease and now it's cured. So you will no longer have, you know, the disease or the virus. So as long as there's a curable mechanism for it, the virus is then killed. But if there's not, and your body is able to kind of keep it dormant, then it will still stay. Now, I don't understand why there's a vaccination for chickenpox, and then you could still get it. Or even if you have the vaccination for chickenpox, you could still get shingles. So it doesn't wear off for that, you know, so that's what's a little weird to me. I don't understand if you have a vaccination for chickenpox and you don't get chickenpox, then how can you get shingles? Because shingles is gonna come from the herpes zoster, right, virus of that. I don't know, but I know I've seen shingles firsthand and that scares me too. But you can only get that vaccination when you're 60. Which I don't understand why. Because you can be prone at it at any
Like
time.
stress.
Anything can bring on shingles. I had a coworker who got it on her back, and we were in our 20s at that time. So it's like, I can't get vaccinated from it, but you want me to suffer
Till I'm 60.
until I'm 60?
Makes no sense.
Yeah. And she was out of school for like,
What was I saying? Okay, yeah, so we already talked about genital ones. All right, so we have the two main ones. We have the primary herpetic gingivitis, which is the primary oral one, and then we have our reoccurrent herpes simplex. So I want you to kind of commit this one to memory as well. So just knowing what's the difference between the primary and the secondary. So primary is systemic, secondary is localized, primary is acute, secondary is chronic. Primary is in children, secondary in teens and adults. Got it. Okay, so we're talking about primary ones. We know this is gonna happen between the ages of 6 months and 6 years old. This is not saying this is the only time this can happen, this can occur. This can actually happen anytime. It's just, this is the most common range between 6 months and 6 years old. So severe cases in adults are usually with their immune compromised or more prone with HIV or AIDS. So symptoms, with this, I want you just to think of all these symptoms when we're talking about herpes as more like the flu-like symptoms. You're all gonna have that lipidinopathy, you're gonna have malaise, you're gonna have a fever, you're gonna have that sick, ill feeling. So if you can kind of correlate that with flu-like symptoms, you really can't go wrong. All right, so 24 hours after the initial symptoms, you're gonna have more of that red inflamed tissue, and you're gonna have a hard time eating and drinking. This can also lead to other areas where you can actually have to have IV sedation, IV intravenous liquid fluid, because you're not able to eat and drink. You're so dehydrated because of the fact that it's kind of encompassing your whole mouth, and it makes it really hard. So after the 72 hours, once the fevers goes down, you get the vesicles, and then you all know the vesicles then eventually will rupture into the ulcers. At that point, what we used to say here is that as long as it was crusted over, you were able to see it's no longer in its kind of contagious state. But through the CDC, that is not true. At any stage, it is going to be contagious. So that's why whenever we see a patient here, we dismiss them. I know when I was even in school, it was always saying once it was crustated, then you were fine. You were able to go ahead and see the patient, but that's not true. So when it's weeping, we already know when it's weeping that it's very contagious because the fluids are then leaking out of the vesicles.
But what makes the crust? The
The-
weeping, right?
Right. So then you have to think about that just because. So I guess at that point they're thinking it's no longer weeping.
But even if you get the like the crusties off, they keep returning, so something has to be weeping, right? You would think.
I don't know, but you saying
Weeping,
crusties and weeping. Choose your words lightly, because I'm like, stop it.
DFO on
It's too much for me to deal with.
I was gonna ask that too, or do we just need to know like the generic symptoms?
Generic symptoms. So that's what I really want you to just kind of take away from it. So not really knowing, knowing the ages of primary, pretty much children. So if you were to think, 6 months to 6 years old, we're doing it. But for time frames, because that can be different. So, but 1 to 2 weeks is here. I found it in your book and I found it in other informations, but you don't really need to know when it spontaneously heals. All right, so palliative care, which is what?
It's when they're
You need
not.
assistance.
Never mind. I
When you
think
need
that-
assistance and help and
Is
you're
that
older.
palliative, like when they're older, they're not gonna get any better, and you're just trying to make their
Just
more
alleviate
comfortable.
essence. So you're just trying to just alleviate the symptoms. So there's really not a telltale, like for example, the common cold. Pretty much anything we take over the counter is going to be palliative care because it's not really curing it. It's just kind of lessening the symptoms and getting you to rest pretty much, but you're not getting over anything. All right, and then topical anesthetics can help to prevent dehydration, and we already talked about IV fluids if there is severe cases where they cannot eat. So that's the sad case.
Don't kiss the baby.
Right.
Yes.
Right. And I wish more people would who have their children.
I've seen a lot of people start putting signs on the baby carriers that says, "Don't touch, don't look, don't kiss."
And
Like,
it makes you seem like a psychotic parent, but
people just randomly kiss babies, and if they don't know, and
I don't even care if I know who, like,
I don't mind being
so gross.
Aunt Lucy over here smooching your baby on the lips, and she got like a big old cold sore, and you're like, ah!
They literally kiss those babies all the time. And I'm like, y'all are so freaking gross.
No, but I took hand
all right. Now, what else would this look like?
You're clean.
And what would you do to do a clinical diagnosis?
White.
Right. Exactly. And then you would also just kind of look around and see if we have the different types of ulcers that are there.
So technically, if you saw that, it could be leukoplakia, it could be candidiasis, and it could be a herpetic gingivitis.
Or isn't there another thing that has like the geographic tongue? Can it have the white around it too with the
Yeah,
red?
but this is more raised. I mean, and
Okay.
geographic tongue can be raised as much, not as raised as that.
And
So
then the median,
rhomboid glossitis.
and that can have the white on it. When
That
you
can
wipe
have the
it off.
right around it as well. So yeah, but you're gonna see more of that
Red.
that red erythematic area right in the center of the tongue. All right, so the reoccurrent herpes simplex. So this one is actually, it's kind of, when we'll get into shingles as well, it's more like shingles. So if you think about this, if you think about chickenpox, just like primary herpes, and then you think about shingles, more of the secondary or reoccurrent one, you're going to notice that it kind of stays in the nerve endings. So this is just going to be latent. It's going to stay there until the trigeminal nerve, which makes up, what makes up the trigeminal nerve?
The ophthalmic, the maxillary, and mandibular.
Very good. At least you guys took
That
something.
seems like a distant memory.
Yes.
it seems like
But
a
I
long
remember
time
Looking at your
ago.
face, she's just
Oh.
like,
It's like,
no, I blocked it out. What's the trigeminal nerve again? Where is that located? All right, so a lot of times what we're going to see is that with if you have a weakened immune system, this is where you're going to notice that you're going to start seeing more of the recurrent herpetics, because as long as our defenses are working properly and we're healthy, this can kind of stay latent and dormant.